Can you hear me? Oh, I can hear myself. How impressive. Thank you. And so we go right ahead and we will see if this baby is in a good mood. Of course, we will always do the usual. Oh, we will keep this a little more straight. Yes. And here we are. And do we have a period idea? So as usual, we have to work out all the important things in life, such as our calendar, and we go right ahead. And it's okay. September. So we have the luxury of using a Ferrari here, and we shall enjoy doing that. This is a machine called the E10, and we're very grateful to GE for making a Ferrari available. I like to do demonstrations on low-end machines so that I can show you that everything is possible. But here we have the luxury. I have a choice of transducer, and the one I love to use is C2-9. But ever since this other one came along, which is a 3D called the RM7C, I now use this as my primary transducer. So that is what we will be doing, and we go right ahead. So let me start with this one, and as usual, keep the hand here, my dear. Yes, thank you. And so we have here, I'm just making it more comfortable for myself, and we're looking at amniotic fluid. Our first bit of the scan, like we do for all scans, is to go from the symphysis pubis upwards, because we wish to actually look at everything and confirm that it's a singleton pregnancy which is alive with a normal amount of amniotic fluid. The placenta is high up and most of it is fundal, and we're happy. Then I go in the midline from the cervix, as you can see here, and go all the way up, and the placenta is basically an upper anterior placenta. This is the head area, singleton pregnancy. I go from side to side and so on, and that's what I would be doing. Remember that the spine has always to be evaluated when the spine is anterior, and when I do that, I realize now this is all being done as a basic overall evaluation, but the first thing I like to do is to increase my angle of the beam. So watch this area here, and we expand to that. So it's now an angle that's about 94 degrees. And I finished doing the spine because the spine is anterior, and this is the best way to look at the spine. And the first thing I do with the spine is to change the depth. So I'm looking at less depth, and my spine comes to the middle. I am then looking at the cervical spine, the dorsal spine, the lumbar, and the sacral, and I'm going all the way down to the lumbosacral coccygeal curve. And while I'm doing that, I'm looking at the skin covering the spine, which is the black subcutaneous tissue and the white skin itself. And while I'm doing that, I try and get a view where I can actually spot the spinal cord and try and see where it ends. So we're following that, and at certain angles we see it, at certain angles we don't, and we keep doing it till we actually see that. And below that, the rest of the white stuff is actually the filum terminale. So that is how we go about it. And then for the axial view, we will turn our transducer around, start at one end of the fetus, and then go all the way up, tracing, 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 and tracing. And we go all the way up, making sure that we're working in a transverse view till we reach the head. So in a routine method, that is what you would be using, and then you record this as we go along, and then you say, all right, now I'm finally satisfied. If you want to locate the end of the spine better, we're now magnifying that area, the end of the spinal cord better, and then we focus down on that. And when I focus down on that, I realize that yes, now I'm working well. Notice that my focal point is just below the spine, and that's where it seems to give the best results, and there are no reverberations therefore, and then I'm able to identify the spine, the spinal cord much better. We then zoom out and we say, okay, let's now look at the cranium. So my standard plane, and most of the cranium is currently hiding behind the umbilical, behind the mother's umbilicus, and we're trying here, and I realize that I have a lot of blackness on my screen. So I increase my gain a bit and try and overcome that. I then try to do this, which is try to manipulate the baby's head to come into an area where it is not behind the umbilicus. While I'm doing all of this, I'm still doing an overview. I'm getting a view of the lateral ventricles, I'm getting a view of the cerebellum, cisterna magna, in non-exact planes, but just to get a good overview. And then I say, all right, I have succeeded in pushing this head to a place where I can see better. And now when I have done that, I am ready to zoom in. So I now pick my actual optical zoom and say here, I will increase the total gain, and then I'm now occupying most of it. The head is now in the middle of my image, and I'm sweeping from up, seeing the lateral ventricles, the interhemispheric fissure. I come down and I see here the cerebral peduncles. I see still a bit of the lateral ventricles. I see the cavum septum pellucidum, and then I end up looking at the cerebellum. When I look at this structure here, I know this is a Blake's pouch, and I know that it's a normal variation, and I will look at it. As an overview, I like to work on 4 of these frames to show you just how different they are from each other. And this one here is the first of the planes. And you say, okay, while I'm doing that, I'm also looking at a few other things. One of them is the bones of the skull, and I'm looking at the sutures, as you see here and here, and here and here. I'm also looking at trying to get my standard plane, and I see my image is too black, and there are 2 ways of doing that. I can change my angle of inclination, or I can change the baby's position again because the baby has moved, and then I will be able to get a good view. So this is something we're waiting for a few seconds, and we say, all right, it's worth it to try to get an exact view because that's going to be my measurement plane. While I'm doing that, I say, no, before that, I got my cavum and I got my cerebellum and I got the back here. I will preserve that as one possible image, but I will improve on it if I can. And then I say, all right, I'm going to now look here and get my next axial plane. And as you know, these 3 axial planes are part of the neurosonogram. And then I'm now reducing the total amount of gain so that I get a better outline of the cavum. And of course, you know that there will be reverberations in the near field, and I will have to come back from the other side and pick up that, and we will do that later. And then we come this way and say, all right, which other planes do I need, and am I getting those or not? And then here I say, yes, I'm getting the plane that I need for my transthalamic evaluation, and I'm happy. And the baby, of course, is now feeling nice and frisky and not staying in one place and jumping all over the place, which is so sweet. And then we say, all right, let me push you around from this side and see if I can trap you somewhere. And this baby is thoroughly enjoying playing these games. And we say, all right, we will wait till the baby is in a slightly less frisky mood. And then we say, okay, meanwhile, am I looking at the other things? You know that we were looking for the parieto-occipital, which is sitting here. And then we measure here, but I don't see the cavum here. So if I don't see the cavum there, then I am not in the correct plane, and therefore I must work on it till I get that correct plane. I got it in between, so now I scroll back. I'm using my cine, and I'm scrolling back, because I remember seeing it somewhere here, and I say, aha, here you are, and then I'm looking across like so, and I say, yes, this is it. I then go on to record further, and we say, all right, let's try and get my other views more systematically. I don't want to get the cerebellum, I want to get as little of the lateral ventricles as possible, and I'm going to pick up in such a view that I should be able to see my cavum nicely, and sure enough. Remember that the cavum is going to become more prominent as this baby is going to continue to grow, and therefore we will wait for that situation. And meanwhile, we will finish our measurements. Okay, so here we go. And you know that the measurements we like to take, of course, are first of all the width of the atrium of the lateral ventricle, which is this one. And you say, all right, here it is, and I measure it along the long axis, perpendicular to the long axis. I will also then go on to measure my transverse diameter of the cerebellum, which is from the widest white portion here to the other widest white portion here. And you notice how beautifully all these babies seem to be coming in at 17 weeks plus, which is quite the delight, but we're happy. Then I measure the depth of the cisterna magna, and for that I say, okay, I will use my other bit of calculation, and I'm happy. And we are here, and we say, all right, I will measure this, which is the depth of the cisterna magna, and then I'm pleased with all of this. And then, of course, I need to move on to do my measurements in my BPD plane. So in my BPD plane, I say, all right, this little stuff has become too big, I will throw it out, and then I do my BPD. There are two ways that ISWAG suggests, and I don't want to confuse you. So I use the old-fashioned way, which is my plus sign on the outer table, perpendicular to the interhemispheric, and I go with my plus sign to the nearer edge, because that is how my data is collected here on this. So the chart I'm using is a Hadlock chart, where I will definitely like to use the way Hadlock originally measured it. The second one I wish to take is the occipital frontal, which is from the middle of the bone to the middle of the bone. And the third one I take is an ellipse. I don't go necessarily by the machine's calculations. They do overlap, but I just feel good to do it myself and make sure how well they're going. And I say, all right, this is where we are sitting. And therefore then I say, okay, we are sitting happily on a chart that gives me these particular readings, and we're quite happy. Wonderful. So the measurements are done, the basic planes are done. And then I have a choice to try and see here, because the fetus is in a breech position, the head is down here, the breech is down there. I will now look for my other planes. And the way I look for my other planes is by trying to get into a mid-sag or a coronal plane. How do I do that? Because the head is still hiding behind, I wait patiently. I go back to my single thing here, and I say, all right, this looks reasonably coronal, and let me see how it is. When I come anterior, then everything gets hidden behind the umbilicus. So I will now manipulate the fetus with my other hand, and typically I keep a foot switch activated, so I don't need 1,000 assistants to help me. I can't afford them in the first place, and therefore I will do this and see what am I getting. And here I am getting the orbits, and you can see the lenses within the orbit. And when I go above the orbits, I say yes. What am I seeing here? I'm seeing one of the coronal planes, cavum in the center, lateral ventricles occupied by choroid plexus, and interhemispheric fissure interrupted. So my first plane will be this plane without that interruption, and I will record that. This is my first coronal plane. My second coronal plane is going to be at the level of the cavum, which at 17 weeks I don't expect to show very prominently, but it's there nevertheless, and I will trace it, and I say, okay, while I'm tracing it, I must try and see my landmarks. My landmarks are the roof of the orbit, also called the sphenoid, then the interhemispheric fissure, and I go backwards, and I try and see if I can spot that. Sometimes very tricky to get this plane at 17 weeks, but we will try and do so. And we say, all right, every time I do that, I end up looking at the posterior plane. My posterior coronal plane shows me here the cerebellum, which is this area here, and this area, which is the occipital horns. I still have to obtain two more planes, which is a transthalamic plane, and we try and see whether I can go through those by scrolling through, and the fetus says, maybe, maybe not, but I said, maybe yes, and we wait patiently. All of this takes patience, and you see the thalami now on either side, And then my last plane left to be done is that very, very important plane without which my study would never be complete. When I was scrolling through this, I said, yes, I did spot that, and here it is. So when you look here, and then again I get my image to the center by post-processing its position, and then I'm able to spot interhemispheric plane, corpus callosum, and then the two horns. And you can see that the system is not as well developed as yet because it is only 17 weeks. We then try and move on to the last three of my planes, and that is to see a midline plane. For the midline plane, I am trying to focus the fetus from the anterior fontanelle. And we struggle and notice that my transducer is almost parallel to the ground. And then we try and watch it like so. When we watch it like so, I seem to be getting somewhere. I reduce the depth I'm working at. I get out of the zoom. I reduce my total gain. And then I say, okay, let me try, and let me try, and let me try. And when we do that, the baby says, you can try, and you can try, and you can try, but I will not show you. So then we try, and we try, and we try. And we don't give it much time because my patients are sitting on my head like all your patients sit on your head. And I say, what do I do? Can I use a possible shortcut? Well, I can make her sit outside and call her back for a review. But then I have a train to catch because I have to get to another city. And what do? I try and see whether 3D can facilitate me to open this whole box as faster as I can. And then can I do some manipulations by recording? Yes, so I change my choice of transducer to the RM7C. You'll notice that this is a phenomenal transducer. Unlike 3D transducers, it has fabulous resolution, almost as good as a matrix transducer. And then I say, what do I do here? I get here, I get to the middle as much as possible, I get to this, I change my depth, I am still on a high overall system gain because that's the best way to do a 3D. I will then pick a 3D box like so, and the right plane to try and see all this in is a transcerebellar plane to try and acquire. I then increase, note my box is about 10 millimeters greater than the area of interest, and I'm trying to pick up as much of the cavum as possible and the cerebellum. I choose a quality which is high, and I say, okay, let me see. And we say, all right, this has acquired, and the baby didn't move, and we seem to have covered everything. And then I have two choices. I can look at it like this, and then I say, okay, I have a dot and have this, but what I need to do is to see the plane so I can direct myself correctly. So let us start with a 3-in-1. And I need a standard referral point. That can be in plane A by moving my yellow dot that you see here, this one, and you watch it moving to either the cavum or to the vermis of the cerebellum, and that would be one possibility. And you could also keep it anywhere in the midline and you could work on that, but I like to work on one of these. So that is what we do. But before I do that, when I'm in my basic plane, I do a walkthrough. I scroll from below to upwards and below to downwards. When I'm going downwards, I move out of my transcerebellar plane and I get to see my Blake's pouch very nicely, which is a normal structure, as you know. And then I move on to the rest where I get my transverse diameter. I move higher and higher, and then I get to see my lateral ventricles, and all of those are still very much there, and that is what I get to see. And then I say, okay, I think I pick up this here. Now, the two ways I can handle this. One is a very simple technique called omni-view, where I will pick up a straight line. Hold on, let me just get back to that for a second. And we say multiplanar. This top image has moved too far to the left, and so I will move it back by saying, all right, come back image, come back to the middle, and I'm happy by making it come back to the middle. And I then say, all right, I will use this as my referral point, and move on to OmniView, and it still doesn't work out correctly. So I said, okay, hold on. I will still get that out of the way, and I will move it even more here, right to the middle, so everything is in the middle. While I'm doing this, I realize that if I move my little dot into that area, I am picking up the cerebellum very nicely, as you can see here, but I'm not happy with my corpus callosum. There could be two reasons: positional, or it could be only because it's not yet that well developed. And so now let me see, when I go to my OmniView, if I'm able to pick up everything. So I draw this line from the back to the front, and this line helps me to manipulate, and I say, okay, I'm picking this up. I try and get a summation of lines, so I press what is called VCI, and when I press VCI, then I realize that it's not helping me because it's not enough thickness, and I say, all right, let me alter the thickness and try and pick it up, and I reduce the thickness, and I say, okay, now I need to move this. Hold on, and I will fix this, and then I pick this up here, and I can move it up and down, and I say, all right, it is developing, but it is still pretty small, and therefore I just about pick it up in the anterior portion. And this is because of embryology. So you can't push embryology beyond a point. Then we go on to pick up our last two planes, which are the parasagittal planes, which you can do like so. And these are easy to pick up in 2D, like here. And you swing to the other side, and you say like so. And then I say, no, I have to work much harder. This is not good enough. And there we are. That's almost there, but we still have to work harder from one side and then to the other side. You see this one here, and on the other side you sweep over and you see the other one there. That would then complete all the planes that you wish to see. If I had a baby that was a little older, then I would have managed a much better neurosono. Usually with babies like this, I go on to manipulate the baby, get the head down, and then go ahead and do a transvaginal evaluation. So then I would do this. While I'm watching, I zoom out and I change my depth, I increase my axis, and then I gradually try and push the baby around. Before I do all of that, I would have emptied the bladder out, so I have more space for the baby to move, and then I would have done it. So that is the way you would go about it. Or if nothing else, just make a wait for a while. The fetus will turn, and then you will try and get what you need to get. So that is the way to go about a neurosonogram. And I think we still have 1 or 2 minutes to answer any questions. Yes. So the baby, as you can see her, is giving me a run for its money. And baby says, between embryology and my position, I'm not going to let you show off beyond a point. How absolutely charming. Thank you.